Hello, everyone. Next, I will briefly introduce our research consent. Thank you for your listening. Predicting macrovascular invasion and postoperative recurrence in hepatocellular carcinoma without peritumoral hyperintensity. Macrovascular invasion is a major risk factor for recurrence after surgery of HCC. Although peritumoral hepatobiliary phase hyperintensity has been identified as an important imaging feature with high specificity for predicting MVI, more than half of patients with MVI do not show peritumoral HBP hyperintensity. Given the importance of MVI in the management of HCC, it is imperative to preoperatively identify complementary features that can predict MVI and tumor recurrence in patients without peritumoral HBP hyperintensity. The aim of our study to identify MRI features of HCC that predict MVI and postoperative recurrence in patients without peritumoral HBP hyperintensity. 130 patients who underwent curative resection of HCC during the study period were enrolled in our study, including 109 patients without peritumoral HBP hyperintensity. Univariate and multi-univariate logistic regression analysis showed that both tonal enhancement and peritumoral HBP hyperintensity were independent predictors of MVI positive status. In patients without peritumoral HBP hyperintensity, the only significant difference in MRI features between the MVI positive group and the MVI negative group was presence of a radiological capture. Kaplan-Meier curves showed that intrahepatic RFS was shorter in patients with peritumoral HBP hyperintensity than in those without. After adjusting potential confunders of age, gender, tumor size, and other radiological features, peritumoral HBP hyperintensity remained significantly associated with shorter intrahepatic RFS. In patients without peritumoral HBP hyperintensity, subgroup analysis showed that tumor size more than 5 cm, non-smooth markings, mosaic nucleosides, and satellite nodule were prognostic factors for intrahepatic RFS. Only satellite nodule was identified as an independent prognostic factor for intrahepatic RFS in multivariate cost regression analysis. A two-step flowchart incorporating peritumoral HBP hyperintensity and the satellite nodule was developed to stratify intrahepatic recurrence risk. The high-risk HCC detection rate was significantly higher using the two-step-wise flowchart that incorporated peritumoral HBP hyperintensity and the satellite nodules than when using peritumoral HBP hyperintensity alone. Conclusion: in patients without peritumoral HBP hyperintensity, a radiological capture is useful for identifying MVI, and the satellite nodule is an independent risk factor for RFS. Thank you.